Welcome, everybody, to episode 27, Practical Psychology Podcast. My name is Joseph. I'm one of the co hosts. Today, we are very happy to have Catherine Cloutier joining us in this podcast. Kat is a METIS woman located in Saskatchewan. She's very passionate about counseling. In fact, she's a certified Canadian counselor right now. And her specialty is OCD, phobias, and anger management, especially with postpartum rage. So, Kat, very welcome for today's podcast.
Hi, thanks, Joseph. That was a more thorough introduction than I'd be able to give.
So, Kat, tell us a little bit about yourself coming from beautiful Saskatoon here first.
Well, it doesn't feel so beautiful today. It's still, several feet of snow on the ground, but yeah, it's warming up here. It's great to be working in Saskatoon as well as a counselor because there's a really, really great need for it here for sure. Um, so yeah, I love it. This is my hometown. I'm here to stay.
We know that there's a shortage of counselors in Saskatoon.
Yeah, it seems to be getting better. But a few years ago, part of the reason I decided to kind of pursue this career path was because, you'd look for a counselor online or something and you'd get placed on a wait list. Or,
Mm.
you go to your doctor and you say, I need a referral to a counselor, psychiatrist, whatever. And you'd be 8 months would be the time frame you're looking at to get help. Um, and it's very discouraging to see that. And then, not only that, but then when you do actually get your appointment, you're faced with, fees and who's covered and who's not covered by your insurance. And so, um, yeah, I really, really saw the need for, especially like a lower cost, affordable, available counseling.
Mhm. So, Kat, here, can you tell us a little bit about you are very passionate about phobia, OCD, the obsessive compulsive disorder symptoms, and also the postpartum rage and anger management. What drawn you in those subspecialty in counseling?
Well, part of what kind of drew me to those is some lived experience with the phobias. So, as a kid, I had several phobias, one of which kind of followed me into adulthood. And people kind of underestimate how debilitating they can be for people.
Yeah.
And often phobias go hand in hand with things like OCD and panic disorder and anxiety and all of that too. So, and the treatment for phobias is quite similar to the treatment that, is most used for OCD. And I tend to favor behavioral approaches,
Mhm.
which exposure and response prevention is generally what I use, and that is a behavioral approach through and through.
Yeah.
So,
Mhm.
it's very natural for me to kind of assume that when I was going through school and stuff, that was my interest area for sure. But also, with that lived experience, it's easier for me to kind of relate when someone comes in and says, I need help with a phobia or, I think I might have OCD. Um, and then, it's interesting because with the behavioral approach, things like anger management also come a little bit naturally as well. And when I kind of had my first big like clinic job, which was the better part of last year, I kind of fell into an interesting niche of helping men through anger management, which was something that, had one client and it just spiraled from there because I enjoyed it so much.
Yeah.
Yeah, and then it just kind of turned into referrals on anger management, and that was what I was kind of being advertised as, and that was what worked for me. But one thing that's often overlooked is women who need anger management. And so,
Mhm.
especially mothers, I find that, once you hit motherhood, you you feel your emotions quite differently, and that includes anger. So, it's really hard to kind of reach out and get help, especially when your issue is that you're very angry, because it's a very
Mhm.
shameful feeling to have sometimes. And people feel very guilty for their anger and the impact on others. So I just feel very strongly about all three of those issues and
Mhm.
more, but those are definitely the three
Yeah.
that, yeah, bring me joy to help for sure.
To get here, I want to focus on the lived experience.
Hmm.
If you're open to share, can you tell us a little bit about the lived experience with phobia, and for the outsiders or people who doesn't have this experience, what are some of the things, assumptions, misconceptions that they might have?
Hmm. Well, I think first of all, the idea that phobia is just a fear is a huge misconception because, you see it all the time. Every time you hear about phobias, people joke about having different phobias and all of that. But really, when you have a full-on phobia, it is debilitating. It can completely derail your life. It can consume your every thought. If you're afraid of something like, let's say, drowning is a very common phobia. If you're afraid of that, you might not even be able to watch a movie with a body of water in it, or fly over an ocean in a plane, or go for, dip your toes in the water in the shallow end of a pool. Just little things that you wouldn't even expect can be very triggering and can send you into a panic spiral and a thought spiral. Um, and so, it, like I said, it can be quite tied with how OCD works in your brain as well, because you've got that, constant ruminating, and often you have kind of like a compulsion that goes with it. So in the
Mm,
case of phobias, the compulsion is usually avoidance. You want to
mm,
avoid everything. Everything has to do with your phobia, everything that might remind you of it. If you're afraid of water and it rains outside, you might have a tough day.
okay, wow. So that even the term phobia is very different, because people use this term in a very loose term every
Yeah.
single day. But for people with really phobia, they have a lot more going on after.
Yeah, absolutely. And I think a lot of it too is the thoughts that go on, and they're just constant. They don't stop. And that's part of my lived experience that I kind of bring to that role, because when a client comes to me and says, I've got claustrophobia, I've got this going on, and I can't even go to work because my cubicle feels like it's, suffocating me. And I
Oh,
get it.
yeah.
Like, I don't fully understand anybody else except myself, obviously, but I come from a different place of understanding, right? So I can come in and say, no,
Mhm.
I can see it from your perspective a little bit because I've been there. Maybe not in that exact phobia, in that exact situation, but um, there are similarities for sure.
Mm. So, Kat, here you're mentioning about for phobia as an everyday language. People say, I have a phobia for spider.
Hmm.
But for clinically, as a disorder or serious symptoms, the phobia leads to the thoughts, the
Hmm.
behavior, and you mentioned the avoidance. And I'm more curious to know about, let's say, for a typical person going to work, what are some of the subtle signs that they can observe on maybe their coworkers, family members, so they know how to support?
Yeah, and a lot of people, a big problem with phobias and living with one is that there is such a huge stigma about it too, because, even when I was dealing with my phobias, it was really hard for me, even as a kid and a teenager, to tell people about them, because it's going to go, in my mind, because especially when you're living with anxiety and panic and phobias on top of, everything else, in my mind, it was going to go one of two ways. And those two ways were that person was going to use that phobia against me in some way, let's say it was a fear of spiders for someone. Well, that person could maybe throw a rubber spider at me one day, and that would
Yeah,
completely derail my day, and I would suddenly have,
yeah,
anxiety about that space, specific space, and all of that.
yeah.
The other way it could go for me was that they would just not care, or they would say like, that's stupid, that's ridiculous. A grown woman being afraid of a spider. I don't have a phobia of spiders, by the way, but just in the hypothetical.
Mhm,
And that, to me, I think that's where a lot of people's brains go. You don't consider the fact that somebody might be supportive. You only consider the fact that
mhm,
someone might either be malicious about it or not care. And so, that makes it really hard to come out and say, this is what's wrong. Because in your head you're like, it's just a fear. I should just grow up. I should just get over it. It's just a fear. I need to
Okay.
just face it and be done with it. Um, to the average person, to answer that question, I would say if you notice that somebody in your life looks, pay attention to people's body language, pay attention to how
Mhm.
they react to you and how they speak to you. If you notice that suddenly somebody is kind of clamming up a bit, or they're always nervous when you bring out a certain object or talk about a certain topic, um, you know, you don't necessarily have to give them the third degree, but you can even just gently say, is everything okay? Is there anything I can do to support you? Um, and maybe reassure them that you're not just
Mhm.
looking for the gossip or something like that, because like I said,
Yeah.
that's where your brain wants to go when you're in that state.
Yeah. Those two things are very nerve-wracking.
Absolutely. Yeah. Yeah,
Wow.
it's a very tough situation to be in, um especially for a child, often a child doesn't even recognize the fear or the phobia, they just know that they're freaked out or that they feel dysregulated, they feel like they're unable to handle a situation or something, and sometimes you don't even know what you're afraid of, especially when you're that age.
Mhm.
So it's really good to be in tune with your child's or, a child in your life and just know, you know,
Mhm.
okay, they're acting strange about something, or,
Yeah.
they're giving off some vibes. They're trembling, they're not speaking, they're hiding, whatever it is. Yeah.
Yeah. Wow. So, Kat, from your clinical experience, um, what are some of the obstacles for people seeking the professional treatment for phobia?
Um, Honestly, I think it's that most of the time you're telling yourself it's not that bad, I'm I'm not I'm not living with, chronic depression that's just constant. I'm not living with a panic disorder that keeps me inside my house. I'm not, I don't
Okay.
have OCD. I don't
Yeah.
not having delusions of anything. So I think it's just the idea that it's not severe because it is kind of played off as that. It's
Mm,
just a phobia, right? And I think
mm,
that's a big problem with seeking help too. And also just feeling ashamed and the idea that,
mm,
this is silly.
yeah, yeah, yeah. Because it looks like the other departments of life is functioning well, and just this
Mhm.
small department here, but from time to time it can explode.
Yeah, absolutely. Yeah.
Yeah, I see. So, Katia, from your clinical experience, the treatment for phobia, um, what are the differences between helping adults compared to helping maybe children or the teens?
I think because kids can um, kind of overcome the thought processes a little bit easier than adults, treating them from a behavioral approach works a lot better, and, really focusing
Yeah.
on that exposure and response prevention. In this case, the response would be avoidance. So basically, you're treating them by teaching them that, okay, here's the thing you're scared of. And now we're going to let you sit with that anxiety, and we're going to teach you how to bring that anxiety down. And so then when you actually encounter it in the wild, in the real world, uh, hopefully it won't evoke as strong of a response in you. And honestly, what you're looking for is bringing that down. And it doesn't have to look like the phobia is completely gone. Doesn't have to be, suddenly you can touch a tarantula and have a pet spider in your house. It just means that you won't be debilitated by the fear on a daily basis anymore. And,
Mm,
in the perfect world, you would get rid of the phobia 100%, but we all know, from working in the field that that's not always possible. So
mm,
yeah, and I think a lot of the times working with adults can be trickier because of those thought processes and how ingrained they have become over the span of your life, and how adults really have that capacity for, things like abstract thought and it's not as simple as just saying like everything's okay, right? Never is. But you've got that ruminating going on often, and
Mm,
it can be very, very strong. And even if you tell
mm,
yourself over and over, like, this is fine, right? I can do this. You don't necessarily always believe it because, as we know, thought patterns kind of develop for us over the span of our lives. So I think treating children for phobias is actually a little bit easier, but not
mm.
necessarily. Like, I think they're both challenging in different ways, I guess.
Okay, yeah, yeah, because Kat, you're mentioning about the general focus of the treatment here, obviously to try to eliminate it, but a lot of times the fear will be there, but just that we can manage the consequence to
Hmm.
be less debilitating, so people
Yeah.
can increase their functioning.
Yeah, absolutely.
Okay,
Yeah.
yeah, yeah. And then for adults, because they are more complex, abstract thinking, they are more defense mechanism to kind of like
Absolutely.
struggle with that therapy.
Yeah, and a lot more
Okay.
unhealthy coping mechanisms that have been developed as
Yeah,
well that
yeah,
really have to
over the
be
years.
kind of taken down a notch to allow the healing
Okay.
to begin.
Okay. And Kat here, can you tell us a little bit about the ERP, the exposure response prevention? Why is it called ERP?
So
For some of the people who
essentially,
don't know.
yeah, it's kind of all there in the name, but basically the process of it, in one sentence is you expose someone to the object they fear or the idea that they fear, and then you don't let them respond to it. So it's generally an OCD treatment, but it's helpful for phobias as well, because basically you're stopping the compulsion that they have. When it comes to phobias, the compulsion is avoidance usually. But with OCD, the compulsion can be any number of things, including rumination. Um, and then, you add in a little bit of taming that anxiety as well that they feel. You let them sit with it and understand that anxiety is not going to hurt them. And then you kind of help them find healthy ways to relieve that anxiety so that in the future they don't have the need to avoid the phobia or, any other compulsion. And so the process is basically you create a fear hierarchy. So, ideally something like
Mm,
10 items. Then what you do is together with the client, you kind of order them. So, let's say if the phobia is spiders, you
mm,
might say something like, okay, the word spider is on the list. That's how bad the phobia is. And that one might evoke a lower anxiety response than, say, touching a spider or having a spider crawl on you. And so you kind of put them in order based on how intense the idea of them is to you. Using a scale, it's called the Subjective Units of Distress Scale, or SUDS. It's all about acronyms in psych. And so you order them. So let's say the word spider might be a 1 out of 10. It might be pretty low. But having a spider crawl all over your skin, that might be a 10 out of 10, right? And so then you order them based on how intense they are, and you slowly go through the list. You don't do it all in one day. You do, a
okay.
couple sessions per item usually, at least, especially for the higher up items. Um, and you don't stop with each item until you bring that number out of 10 down. So it could be, if it starts as a 5 out of 10 and it's still a 5 out of 10, you can't move on. You got to keep you got to keep going, and in that case you might even jump back a level and start and continue working on things that you've already thought that you've brought down. Because yeah, it can be really really hard in a clinical setting to kind of do that as well because, you're working with the idea of the fear, you're not facing it in real time, in real life.
Yeah.
Um, unless of course you've got access to safe ways to kind of, let's say expose someone to spiders or, obviously you can print out pictures and stuff like that, but
Mm.
um, you can't account for every single time someone might see a spider in their life.
Oh, yeah. For the viewers here, the ERP, the exposure prevent response prevention therapy is an evidence-based treatment model, first line of treatment for people with phobia or OCD symptoms. And Kat here, can you tell us a little bit about how a sample session looks like in therapy when the clinician is doing ERP?
Yeah,
How long
so
is it?
yeah, so how long Generally we do, 50 minutes, a therapeutic hour, as they say, leaving a bit of time, extra time at the end to, book the next appointment and have time
Mhm.
in between sessions. But yeah, about like 50, 45, 50 minutes. Um, and you basically, assuming you've already kind of created that fear hierarchy, you already have a good enough
Mhm.
relationship built up with the client that they feel safe and comfortable in your office. You really focus on, you start with a check-in. How have things been? Try to keep the check-in pretty short because we are kind of, you know, our time is very limited in these sessions, especially for things like this. And there's two different types of exposure that you can do. You can do what's called systematic desensitization, which is basically imagined exposure, or you can do what's called in vivo exposure, which is literal exposure right there. And so, for example, if we're doing imagined exposure, as a clinician, you got to do a lot of creative writing and a lot of thinking on the spot, because what you're doing is you're describing the experience vividly to your client while they close their eyes and imagine it and try to really visualize it. And that might not work for a client who has difficulty visualizing, um, you know, videos in their head or seeing images in their head, because I've had a couple clients who have had difficulty with that. Um, but if that's your only option, that's a good option, especially for virtual uh, video counseling. You don't can't
Mhm.
really do the full exposure for that. Um, and if you're doing in vivo exposure, you'll just have something ready. So a picture of a spider, let's say, right? Hold it up. First you ask them, what's your out of 10? What's your units of distress right now? It's a 5. Okay. Hold up the picture, let them look at it, let them feel the anxiety rise in their body, and then you can always give them an out if they feel like it's too intense and they need a second. You can say, we can step away and come back to this later, but that's the whole idea of the exposure, is that you're going to feel uncomfortable. And so then what you want to do is you want to help them bring their anxiety down. You want to help them not run away, right? And so while they do always, the client should always be in control to a certain extent. Um,
Mhm.
but again, that is the idea of the exposure therapy, is that they're kind of out of control. So, you want to kind of just give them the tools to bring their anxiety down, which hopefully you've already run through, before you even built the fear hierarchy. So a lot of my clients like to do progressive muscle relaxation. Um, when I was doing more in-person stuff, I had a client who liked to go for a walk. So we would just go outside, go for a little walk, and just bring that anxiety down in a natural, healthy way. And then say, okay, what unit of distress are you now? Okay, well, hopefully it's lower than a 5, but if it's not, that's okay. And then you kind of keep doing it until you get to a point where it's like, okay, there's 5 minutes left in the session. We're going to do a check-in. We're going to talk about what happened. We're going to see how you're feeling. If you think, how you feeling about handling seeing a picture of a spider going forward, kind of thing.
Yeah. Okay. So, Katia, we talk about the exposure and then the response. And you mentioned some of the response is avoidance. So, in a clinical setting, how can you tell apart what is healthy avoidance or unhealthy avoidance to target for that response prevention? For example, for a typical person, you might want to avoid, a spider
Mhm.
crawling on you.
Yeah. Yeah, and I think the idea is that, is it dangerous? Is it going to hurt me? Is it harmful?
Mm-hmm.
Obviously if it's a venomous spider, yes, absolutely avoid it. I don't care if you're getting over a phobia, avoid that.
Yeah.
Or if you have an allergy to it or something. But generally speaking, if it's, you know, you've had a lifelong phobia of spiders and you're trying to get over it, any avoidance of a spider that is, you know, not because of the danger it poses to you is unhealthy.
Yeah, okay. So that's how you differentiate those, okay?
Yeah, absolutely. Because most people don't avoid going into their own backyard on the off
Mhm.
chance there might be a spider crawling on the fence.
Okay, so that is very extensive.
Yeah. Yeah, and it's one thing to see a spider and maybe scream. I've been there, but it's another thing entirely to say, yeah, I don't go outside.
Yeah, okay. So, Kat here. It's good that we covered the phobia and the ERP. And now I want to talk a little bit about your other passion, about anger management.
Mhm.
So tell us a little bit about maybe your early experiences, maybe the first time you do anger management with men, how
Mhm.
does it look like? And yeah, what is the expectation and what actually happened before the
Yeah,
session?
and I was really nervous to do anger management with men, especially because I was doing a lot of in-person counseling at the time. And so I was a little bit nervous because I got my start virtually, right? I got my start through Free Counseling Society Canada and kind of continued on virtually from there. So one of my first in-person clients was an anger management client and a
Mm.
man. And honestly, I think I'd only had one male client before that, and it wasn't for anger issues. So
Yeah.
I was nervous and I didn't think I could really relate as much. When I'm not typically a very angry person, but when I had my baby, I kind of started to feel differently and felt those emotions shift. And I would sometimes get hit with this strong, uncontrollable anger. And it was so unlike
Yeah.
me to have
Mm-hmm.
that. And
Mm-hmm.
so, that also kind of made me a little bit nervous because I was still kind of in that state of, every now and then I'd still have a moment where I'd be like, I'm so angry and I don't know how to deal with it. Um, but what really drew me to it actually was I just kind of I studied up on it and I looked up all the techniques and everything and I was like, yeah, this is just so like first of all, the behavioral approach is so it resonated with me so highly. It's so great and it was easy for me to naturally kind of fall into that role. And I met with the client, they were super nice and they were super chill and calm. And I wasn't expecting that because I kind of just expected that if you are in anger management, you're probably always angry, which is not the case. Generally speaking, it's just, the amount of percentage of time that somebody's actually angry in their day is very minimal. It's just that the anger is extreme. And, after my first session with my first client, I remember saying to them, anger is a healthy emotion. It's aggression that is
Mm-hmm.
unhealthy. And, they came back to the next session and said, like, that line alone made me stop and think when I got angry again next. And so hearing that something I had just said as a one-off that I didn't think was important really, really kind of made me stop and think myself and think like, you know, anger management clients, they often show a lot of change very quickly because a lot of the time, especially with men, their whole lives they've been told your emotions are not okay. You're not allowed to be sad. And so a lot of the time the emotion comes out as anger. Anger is a protective emotion. So, if you're feeling anxiety, sadness, excessive worrying, whatever it is, and you aren't used to dealing with it because you've been told, no, you got to hold those in, eventually
Mm-hmm.
it's going to come out in an extreme way because it's been bottled up, and that's anger. So honestly, it was awesome to be able to like bring that out and say like, what do you think is going on behind that anger, right? And I had one client who's like,
Mm-hmm.
well, I was upset because I felt like I was being disrespected. And then it was like, well, what does that disrespect make you feel? Well, it makes me feel sad because I feel like my wife doesn't think of me on the same level that she thinks of herself. And then it kind of, you get to the root of things. And even that dissection of that alone is enough to really change the perspective. And then you add in the behavioral, which I love, which is just basically finding interruption points along the anger cycle, um, and really just figuring out which one works best for you and then committing to that change. So if it's something like the physiological reaction of anger, right? And you can find a way to bring that down, sometimes the anger doesn't escalate. So,
Mm-hmm.
yeah,
Yeah.
I really enjoy working in anger management, so I could literally talk about it for days.
Hey, so Katia, you talk about my anger management.
Mhm.
There's a lot of important concepts here. Can you explain a little bit more? Because for the typical population, people are unaware of psychology. Um, they typically associate anger with aggression together.
Mhm.
Can you tell us a little bit about how psychology look at actually they're two different things?
Yeah, so like I mentioned earlier, anger is a protective emotion. It's a very healthy emotion to feel. Everybody should feel angry at some point in their life. Um, angry because, something, it could be anything. Angry because something really annoying happened to you. Angry because a great injustice happened to you. Anywhere along that spectrum, you're allowed to feel angry about it. And you
Mm,
should feel
mm,
angry. But when you take that anger and move it from, thinking, I'm mad, I'm angry, I need to go scream into a pillow or something, go for a run. When you go from that, that's perfectly healthy. That's good. You do that. But when you move on and suddenly your anger is coming out as, you know, punching walls, yelling at your kid, sending a mean text to your boss, whatever it is, that's aggressive anger. And so in that case, you're committing aggression against somebody else or yourself, or honestly, just your property. And that's when it's unhealthy because it can spiral so easily from there. It can spiral from hitting a wall to hitting, a spouse or a child. It can spiral from sending a mean text to yelling at your whole, you know, teammate or teammates in the office, to yelling at all your coworkers. It can spiral very quickly from saying something mean to just full on screaming, to, getting mild road rage in your car, to physically blocking someone as they're trying to drive down the street, getting out and trying to punch them. It can spiral very quickly. And so that's what we mean when we say the difference between anger, somebody cuts you off in traffic and you say, well, screw you in your head, to full on aggression, which is actually trying to harm them in some way. And so that's when it becomes very unhealthy. And that's usually when people have a problem and often don't want to acknowledge it.
Yeah, great explanation here, Kat. Okay, can you tell us a little bit more about what are some of the differences working with women and men in the anger
Mhm.
management settings?
Yeah, actually, so when men experience anger, it's very visceral and it's very obvious. Like they feel it rising in their body, they feel hot, they feel, they feel out of control. They just feel very much so like they want to commit aggression. And I'm not saying that's the case for all men or anything. But that's the typical symptoms I see is, when they come in and they look at me and they're a little bit sheepish and they're like, yeah, I yelled at my kid last night and then I slammed a door. It's always stuff like that. And when it comes to women, often when women are feeling very extreme anger, um, their symptoms of it are a lot different. The aggression is a lot different. Sure, there might be some yelling and slamming and things like that. But sometimes this comes out as very, panic or anxiety or, um, very different bodily sensations like, stomach upset and stuff like that. So it can be, and I
Oh,
do also feel like sometimes men are kind of more allowed to be angry, whereas women feel as though they are not, because they're supposed to kind of be the ones mediating and holding everything together and, the natural caregiver type, I guess. That whole kind of um typology of like, okay, no, you're a woman, so you're a caregiver. You've got to be nurturing. You
mm.
can't be angry. You're not allowed. So I think there's different stigma and guilt levels associated with both.
Also, in a way here, Kat, I mean, for a general sense, working with men with anger issues is more, uh, you look at anger, you address the anger. And then for women, you kind of have to kind of dissect it. It might come
Mhm.
across as anxiety, but actually it's anger.
Yeah.
Okay, yeah,
Yeah.
okay.
And when I was kind of looking into postpartum rage and things like that, it's not a clinical term. It's not in the DSM or anything like that, but it is kind of a part of postpartum depression and postpartum anxiety and kind of those things where you have such big changes happening to you, not just hormonally, but in your life, suddenly
Mm.
your role in life has completely changed. And so sometimes people can be stuck in that state for a very, very long time. And, they say postpartum depression can only last a certain amount of time because it's based on the hormones and everything, but that's just not true. It can last the rest of your life if you're not careful. So I think the same goes for postpartum rage as well.
Yeah, because you mentioned about in the postpartum, there's a lot of changes, hormonal
Hmm.
changes, the job changes, the child
Hmm.
caring, and the baby screaming,
Yeah.
and the sleep deprivation, and there are many things going on, many changes.
Absolutely. And you can't engage in hobbies that you used to like to do, and you can't see your friends as much as you want, and your relationship with your partner, your family, your friends, it all changes. So that can be a lot to handle. And I don't blame women for getting, postpartum rage in any way, because how
Yeah.
could you not?
And Kat here in the subspecialty of counseling,
Hmm.
and right now, women with postpartum symptoms, no matter it's depression, rage, or other issues, is under supported, and there is a lack of counseling professional in that area here. How would you advocate for that? Or even for more people to seek help?
Yeah, well, and I can speak a little bit on lived experience here. You know, I I didn't struggle as much as a lot of my clients and stuff after I had my kid, but one thing I noticed was that when you go in for your checkups and everything, they give you like a 2 or 3 question mental health checkup. And so it'll say like, are you having thoughts of suicide? Are you having, you know, how are you able to, what's your anxiety out of 10 or whatever, right? So easy. They don't assess you. You can circle whatever you want. And obviously they're gonna go to an extreme if you're saying yes to having thoughts of suicide, then there's a whole other slew of things that can happen for you. And a lot of people, it's just so easy to say, no, I'm not. Or, my anxiety is a 2 out of 10, I'm good, You just mark it off on the form. And so they don't do that very
Mhm.
much. You get like one or two postpartum. I was very lucky to have a very attentive physician for myself postpartum. But I know a lot of people who weren't so lucky, and they had a nurse give them a 3 question assessment and then say, all right, you're good to go. And I think that's part of the problem is that women are not accurately assessed after giving birth for mental health problems. You're assessed, your baby's very, very much so assessed for everything. Um, but even physical problems, they're often overlooked, like women who have given birth recently. Once the baby's there, it's the baby, not the woman. And so I think that is where there needs to be a big change. And I would imagine like across Canada, it's very, very similar experience.
Wow, a big change is needed. And
Yeah.
also, can tie on to your three screening questions. And a lot of the women might not be even comfortable to circle yes because they might worry about the Ministry of Children and Family or
Hmm.
what they watch on TV. They will get involved.
Yeah. Yeah, and you don't want to risk being taken away from your newborn baby because at
Yeah.
that point too, you do still have all those really strong hormonal changes happening to you too. Um, And that can be very, very, very frightening because everything feels a lot more intense and extreme. I can speak from experience on that in the first few months of having your baby, especially right at the beginning there when you're getting those questionnaires.
Wow, I see. Okay, yeah. So right now, Kat, it's about people with postpartum symptoms, rage, and other symptoms. And what are some of the interesting things you want to say to the public that they might not know?
Just first of all, it's okay to seek help because I know that's a big problem for some people. And people like us, people who are here to provide counseling services and help you through it, we aren't here to judge you. We aren't here um to take your child away from you, in order to get help and in order to be a healthy mother to your child, you have to you have to, tackle those issues and you kind of have to take care of that because it can spiral so easily. And that's how things like postpartum rage kind of really set in because you go underdiagnosed or underhelped for so long. Um, and another thing too is, your partner should be helping you as well. And if they're not, that's another conversation that needs to be had because sometimes
Yeah.
all that stress can be eased just by a supportive partner.
Yeah. So in a way here is the individual support and also the system, the
Hmm.
family sort of teamwork support.
Yeah, absolutely. And if you're feeling like you have overwhelming feelings that are beyond the norm, you probably are. And it can be so quick for other people to judge and say, oh, well,
Mhm.
obviously you're feeling depressed. You just had a baby, the baby blues. It's not always just the baby blues. Often there's
Mhm.
an
Mhm.
underlying issue there that is very intense and very extreme.
Yeah. Wow. So Kat here today, we talk about a lot of different topics here.
Yeah, more
And
than I was expecting.
and we have really even more to talk about here, but we have to be mindful of the end of time here. So Kat here, if some of the viewers, fellow clinicians want to contact you, we'll also put those into the comments on the description here. What would be the easiest way to contact you?
Probably through email. Or,
Mhm.
I've got my phone number and stuff kind of all up there. I'm available through Wong Counseling as well. Um, yeah, and you can Google me and find me. I've got a pretty uncommon name, so
Right, yeah, wow. So Kat here, we have to invite you again, ASAP, okay? But otherwise, we'll say goodbye and thank you so much for today, Kat.
awesome. Yeah, thank you so much, Joseph. Talk to you soon.